My name is Anshu Banerjee. I work for WHO, and I'm co-chairing this panel together with Debra Jackson, who's sitting there at the end of the row. Just to give some context, maybe, in 2015, we had the Global Strategy for Women, Children and Adolescents Health for the years 2016 to 2030. And this was very much aligned to the SDGs. And many of the indicators that we identified in order to monitor the implementation of this global strategy are aligned to indicators around the SDGs. And we identified 60 indicators that we thought would be useful. And around, I think, 34 are aligned with the SDGs, and another 24 come from the 100 indicators network, list of WHO. And we did an exercise to look at where is the data currently coming from and what would be the ideal situation in 2030. And we noticed that at the moment, most of the information is actually coming from surveys. But if CRVS would be fully implemented, let's say, most of this information in 2030 could actually come from CRVS data, or a lot of these. And so that's, I think, why we as people in mother, child and women's health are very much interested in strengthening CRVS. And at the same time, I also think looking at inclusive development and multisectorality, I think there's a very clear link here as well, in the sense of when we look at early marriages and the impact of young girls getting married, teenage pregnancies, and the impact not only on their lives but also on their children, so the next generation. By preventing early marriages, we prevent teenage pregnancies, we keep girls in schools, they're better educated, they can get employed, but also their children can benefit from the mother's education. And so we also have that intergenerational link that we can sort of disrupt and therefore have better health for the next generation. And so I think, again, a reason why we are interested in CRVS. So we're looking forward to this session. We have a panel of 5 speakers, and most of them actually are highlighting experiences from country level. And so except for Sana, I think, who will give us a sense of how we could look at CRVS as a determinant, as a social determinant of health. The other speakers are all going to highlight country experiences and what we have done so far at country level. And maybe I will just introduce them one by one now, and then we can go into the presentations. So we have Maletela at the end, who works for the Global Financing Facility, which is hosted by the World Bank, and she provides advice and strategic direction to the development and operationalization of the business plans or investment cases for the Global Financing Facility, particularly on CRVS. And so her presentation will show experiences from a number of countries where the GFF, or the Global Financing Facility, has invested in CRVS. Then we have Boonchai, who is the chair of the Asian eHealth Information Network, which promotes better use of information communication technology, or ICT, to improve health. And he will present particularly the link between CRVS and the National ID, and in relation to achieving universal health coverage in Thailand. Then we have Bhaskar, who works for UNICEF in Tanzania, and is the child protection specialist working on the implementation of the new decentralized birth registration system there. Earlier in a previous session, he already presented on the 5 changes that they had introduced in Tanzania. But I think his presentation in this session will focus more on, in depth on the role of health facilities in CRVS. Then we have Kathryn, who works in the epidemiology and surveillance team at the Bill and Melinda Gates Foundation, and she is overseeing the countrywide mortality surveillance for action grants, or the COMSA, in Mozambique and Sierra Leone, and also managed the portfolio on investments for improving the understanding of the cause of death for children under 5. And so she will focus on her experiences, or the experiences of COMSA in Sierra Leone and Mozambique. And then we have Sana, who has worked particularly in health system strengthening, research, and mother and child health monitoring with a number of players like WHO. She worked on accreditation at the Canadian Accreditation Council with UNAIDS, USAID, and now she's working with the IDRC. And she will talk about CRVS as a social determinant of health. So, having said that, Maletela, over to you.
Thank you. Thank you, Anshu, for a good introduction, and good afternoon. I'm the fourth board, and I don't usually do things first, so I'll try and behave like a firstborn. Okay, I'll be presenting on strengthening of civil registration and vital statistics systems through the reproductive, maternal, newborn, child, and adolescent health and nutrition agenda that is part of the Global Financing Facility. I think we got a good highlight in the morning in the plenary about the GFF, the support for GFF in CRVS, so I'll not go into details. But I just wanted to highlight that the GFF is a financing arm meant to bridge the funding gap for the health of women, adolescents, and children. So that's the whole agenda of the Global Financing Facility. And it tries to accomplish that through closing the 33.3 billion gap for reproductive and maternal and child health through efficient use of available resources, scaling up financing, prioritizing spending, and then crowding resources, including providing support through the GFF Trust Fund as well as allocation of IDA and IBRD. The main focus of the GFF is on results and mainly looking at having better sustainable reproductive, maternal, newborn, child, and adolescent health, including nutrition outcomes, by strengthening systems to sustain the outcomes. And this is done, as I've indicated, through value for money and total value of financing, which countries get from their internal domestic resources, financing from the lending operations using IDA or IBRD, these are the lending operations from the World Bank, external financing, and private sector resources, but also looking at making sure that families don't get poor because of the spending that they have on health. And the GFF drives these results through three main ways: prioritizing and basically identifying priority investments to achieve RMNCH outcomes, and also identifying priority health financing reforms that are required for that. I'll not go into details on these because my main interest is on CRVS. But the key also is having coordinated ways of doing things at country level, and I've just highlighted this but making sure that there's financing that is sufficient to implement. And specifically look at learning through strengthening systems to track progress, learn, and course correct. And this is where we have CRVS as part of the agenda of the GFF, mainly to be able to track progress that is made in ending preventable maternal, child, and newborn deaths. So this CRVS is a priority area mainly for the GFF because, as we have noted earlier in the presentations, even yesterday, many GFF-supported countries or many countries in low and lower middle income countries have inadequate monitoring and evaluation systems. We still depend on household surveys or censuses to be able to get data on 5-year or every 10 years. And CRVS is linked mainly to a broader GFF agenda on improving data for decision making. It's a good source of data. We're able to get data at national and subnational level, which we are not able to get from other sources. We get reliable data on age, which we need specifically for indicators such as stunting and neonatal mortality, and it's critical for monitoring progress towards the SDGs. But also, we are supporting CRVS mainly for the basic human rights of women, children, and adolescents. And as indicated in the session earlier, Canada provided funds specifically earmarked for CRVS within the GFF because it's one of the areas that are not well funded. Now, we have a total of 26 countries that the Global Financing Facility is supporting. The ones in black are the old ones, but we have just recently added 10 additional countries that are supported by the GFF. But what I wanted to highlight here is in total, there are 67 low and lower middle income countries that are eligible for GFF support. And the 26 countries that we currently have account for nearly 60% of the financing gap that is required for promoting women and children's health. Now, moving specifically to CRVS activities within the RMNCH agenda, because that is where CRVS is supported. For the initial 16 countries, some had CRVS in the investment cases. And the focus areas of strengthening CRVS through this project is expanding civil registration services, mainly through increasing registration service points and mobile registrations. And I've given examples of countries that would like to have strengthening capabilities in these areas, recruiting additional staff, and using health facilities or schools for birth registration. There are activities to support advocacy and awareness creation, of importance mainly because of the poor quality of causes of death, is recording of causes of death and application of ICD, the revision of the legislative framework, computerization, interoperability of systems, but also the broader engagement of having stakeholders engaged and coordinated well within the country. Now, financing CRVS within the RMNCHN agenda is mainly done through in terms of private sector, it's one of the financing mechanisms that we use, but the countries that we currently work on, we are still trying to see how best we can engage the private sector, which is one of the key areas we are looking at. But the financing sources are mainly the domestic resources that countries have towards CRVS. Then we have the GFF Trust Fund, which is operationally linked to IDA. And I just want to emphasize on that point in that the link of the GFF Trust Fund to IDA, this is the lending operation from the World Bank, increases the scale of financing for CRVS. It's also an important step towards government ownership and sustainability, as the allocation from IDA is on government budget and is government spending, so which is based on concessional loan. So the key thing is trying to get more resources towards a CRVS. I think earlier the presentation on Cameroon shows a wide financing gap that is required to fulfill the needs of CRVS. So it's mainly looking at the other areas that we can use to be able to have more resources for CRVS. But what we have also introduced in the project, because we are working through World Bank operations, is have incentives for strengthening CRVS, which include program for results and performance-based financing. And I'll show a few examples on those. And we are looking at integrating CRVS in RMNCH, mainly using health services, as well as some innovations that we have within the health projects. Now, for the program for results, I made an example here of Mozambique. The project was approved in December, but it's still waiting to be made effective. But one activity here is to improve death and cause of death reporting in health facilities through using disbursement-linked indicators to strengthen CRVS within the DHIS system. So basically, in this case, the government will get an incentive depending on the number of deaths that are certified in health facilities, are ICD-10 coded, are reported in the health information system, and sent to the civil registration for registration. So this, the country will get an incentive for achieving that indicator. Performance-based financing, we had an example of Cameroon this morning where it's being implemented at community level, health facility, and district level, where a health facility will be given an incentive for registration for all deliveries within health facilities, the auditing of maternal deaths, but that is supported by training for the PBF program, which also include birth and death registration from the maternal and death autopsies. The same is done for Liberia, done at secondary level and also linked to the CRVS system. So this also looks at providing incentives for birth and death registration, but focusing mainly on maternal and neonatal deaths. But also within the project, we support civil registration through the use of maternal and child health services, which is currently being implemented in Kenya and Liberia. For Kenya, we are training country managers, and there's support for training country managers at national referral hospitals on using maternal and child health strategies during supportive supervision visits, as well as linking clinics and outpatient departments to register all births. For Liberia, there's been training on people who provide vaccinations and other birth registration services, but also integrating birth registration with childhood immunization services. And we are also looking at community health structure. I think the previous session highlighted the importance of community structures in registration. Liberia, use of community health assistants to carry out recording of births and deaths in communities, but still prioritizing maternal and child health because that's the focus area of the project. In Kenya, we are looking at capacity building to sensitize community health workers in reporting both births and deaths to registration agents. Additionally, there are some pilots that are being carried out. Kenya is supporting mobile registration in hard-to-reach areas, prioritizing the areas with high birth registration, with high number of births but low birth registration. Uganda is the same for mobile registration, and in Ethiopia we are piloting birth and death registration system at community level. But also we are supporting the electronic systems within the RMNCAH projects. Ethiopia, it's mainly looking at digitizing the civil registration through electronic registration system. Doing the same, Uganda, Liberia, and Cameroon trying to link civil registration to the district health information system. I just want half a minute to highlight the challenges that we have noted through this work. Lack of coordination among development partners in the countries. I think we still don't have that that good coordination. But even within government departments are not well coordinated, resulting in parallel system and some institutional arrangements in registration processes, particularly notification, registration, and issuance of certificates. These are still not well coordinated, such that we lose a number of registration, just end up with notifications. But also we have these competing priorities in different sectors, health, ID management systems, which can be well coordinated. But also we have huge financing gap for civil registration if you look at our strategic plans, mainly because of lack of proper prioritization of civil registration activities. But also urgent need for data such that countries start to look at alternatives. If civil registration is not working, what else can we do? Which at the end, I'm afraid 10 years later, we'll still be talking about dysfunctional CRVS system because we've looked at alternatives. But on the last note, lessons that we have learned, it's important for the country to take ownership of the activities that are being undertaken and take the lead. We need to prioritize properly so that we are able to achieve something within the civil registration system. Look at efficiency. In some cases, we are not efficient in the way we do things, but also be able to get financing that we need to have well-functioning systems. But also of importance, we still rely on the DHS to come after every 5 years to tell us how well we are doing in birth registration. We are not able to monitor. We know that death registration is less than 5%, is less than 10%, is less than 30%. It could be anyway. So we need to have ways, even if it's 2%, we need to say it's only 2%. On that note, thank you very much.
Thank you very much, Maletela, and thank you for keeping within time and highlighting different approaches that the GFF has supported in countries, whether it's increasing points of registrations or working at the community level, prioritization of areas, and looking at inefficiencies. So our new Director General, Dr. Tedros, always says that universal health coverage is a political decision that countries need to make. And Boonchai is going to tell us a bit about the link between CRVS and UHC, universal health coverage in Thailand.
Thank you. I think the session about the CRVS and the universal unique identification number also just the previous session in another room, and I just repeat the experience. But this is in Thailand, and another country also has a very good experience like Slovenia, Korea. And this is an experience I mean the case study in Thailand that how the civil registration system contribute to another system, and also the unique identifier, national identifier helped Thailand achieve the universal healthcare coverage. I think many of you already know about Thailand. Thailand is a country in Southeast Asia. It's 60 million people. And for the civil registration system that I always tell our friends that it might be the lucky of the country that we implement the centralized, computerized population database 40 years ago. And the reason that the country implemented that is not for health, it's not for education, it's not for welfare, it's for the securities of the countries. At the time that after the Vietnam War, the government are trying to identify who are the Thai citizens is one, and also to get the voter roster for the election. And the Ministry of Interior, the government assigned the Ministry of Interior to computerize. At the time, the computer technology has come. They use the mainframe, and you can see in the picture that they use hundreds of people entering the paper registration that already be for 100 years into the computerized system, and it managed by the Ministry of Interior. And it takes almost 6 years to populate or digitize the record into the system. And after that, it had been used for many systems. Thai Ministry of Public Health are responsible for the vital statistics. And in 1996, after I think 4 years of they complete the populate the database, they provide the online birth and death registration data to the vital statistics system, to the Ministry of Public Health. And after that, the vital statistics that produced are increased or improved significantly, both timeliness, quality, and also the count of the birth and death. And in 2001, the new elect government enact the National Health Security Act to implement the universal healthcare coverage to all Thai citizens. Before that, 40 years ago, there is also several try to expand the healthcare to the uninsured. But in 2001, we enact the National Health Security Act. And within 1 year, we can implement it, all the uninsured into the universal coverage scheme, which is responsible for 47 million people, or around 75% of the people. And it kind of the surprise to many countries that how well with the policy and then implemented within 1 year. We take 6 months, starting it with six provinces, and then another 6 months expand to 15 provinces, and then after 1 year expand to 77 all across the countries. The lesson is that we have the civil registration system that has all also have the unique identifying number, and we those civil registration and national identifier, the identifier that we call the personal identifying number, enable and facilitate the enrollment of the universal coverage scheme beneficiary. So with the total population, and there is another two insurance, the civil servant medical beneficiary scheme and the social security scheme. We just deducted the people who in that two scheme to cover in the universal coverage scheme. So this has been one of the big success of implementing the UHC, the Universal Coverage Scheme. And not only facilitate the implementation, but also the civil registration and national ID also support the healthcare services in the countries. First, because of the linkage between linkage database between the National Health Security Office, which responsible for the universal healthcare coverage scheme, the data linked with the civil registration from Ministry of Health. So we can generate the database to identify who is in each insurance scheme, and the provider and the patient can be checking their benefit online. The second thing is that because of we have the national ID system, and then we can link all the data when they use the utilizing services in the hospital, and we can gather all millions of inpatient record and developing the case-based insurance payment system that can be cost control for the inpatient, for the healthcare services. So this is because of the linkage between the because we have civil registration, national ID, which is integrated into the one system, and then provide this kind of the identification to the healthcare services. And also, this can be the healthcare provider use this kind of the number and identification to link all the medical record that actually not medical record, it's the administrative data for the reimbursement, which has a medical or the clinical data into that, and then can be provide the continuity of care. This is a sample that for the national AIDS programs using the national ID number and the registration to link up all the record from the hospital, from the lab, and from the insurance to provide the healthcare service for the ART drug to the AIDS patients. And HIV is also covered by the universal healthcare scheme. So at the same time, when the universal healthcare coverage also improve, not just the one way that the civil registration facilitate the implementation of the UHC, but the UHC itself also benefit and improve the civil registration system. Because of having the national ID number is essential to obtain free healthcare service and government child support. So the mother delivery birth in the hospital, then they will go to the registrar to register to get the national ID, and then they will be eligible for the healthcare services. So this is a strong motivation for the parents to register for their children. Before, we have allowed 10% of the unregistered children because of the parent is not, not concerned of the registration until the children are going to the school that they ask for the birth certificate. But with the UHC, then the percentage of the birth registration are increased, and then it's more complete now. And this conference is about the innovation. Right now, government try to use, are using the national ID for the many services, public services, banking, and also public and private are using this, and they they are now implementing. They call the national digital ID, which is try to linkage or and setting the system to verification and prevent. Control the privacy and confidentialities of the people, and also expand the public service, service for the public and the private. And the model of the national ID, national digital ID, is similar to the model in the report of the World Bank Group report on the ID for the integrated approach that they propose the ID for the integration model that integrate all the registry, not just the civil servant or the CR system. Okay, I think time is up, and I'll finish my presentation now. Thank you.
Thank you very much, Boonchai, for highlighting how the decision to introduce UHC actually made use of the existing CRVS system, and at the same time how the fact that in order to get access to free healthcare you had to be registered, and therefore that also stimulated better birth registration. Our next presentation is from Bhaskar, who will highlight again the role of the health sector in strengthening birth registration, and his example will be from Tanzania.
Good afternoon. This is an example from Tanzania on how linking CRVS with health facilities can help bridging the gaps. If you look at these numbers, these impressive numbers from the health facilities, then you try to compare with low notification and certification rates. This is clearly, these are missed opportunities. Of the 5,542 births taking place every day, only 637 births get registered. And this adds to a backlog of 204 births every hour. In Tanzania, there are about 7,800 health facilities. They are closest to the community and have maximum penetration. If you look at the distribution by regions, I think every region has about more than 150 health facilities. This is a brief history about birth and death registration in Tanzania. It dates back to 1917. The existing Birth and Death Registration Act came into effect in 1921. Registration was compulsory only for non-Africans. Compulsory registration from natives started through government notifications gradually in 1980s. After that, health facilities and ward offices were mandated to notify events. Registration was made compulsory for natives throughout Tanzania in 2009 only. However, majority of the village executive officers are not even aware of this responsibility. Even notification at health facilities are incomplete and suffer from issues of awareness, commitment, and supplies. In 2013, decentralized birth registration system took off in Tanzania. Now it's in operation in 9 regions. This year, in March, we are going to decentralize death registration on pilot basis in 1 district in Tanzania. If you look at the barriers, there are issues of distance, cost, low awareness, low demand for certificates. There are cultural issues like delay in naming a baby, registration of a baby of an unwed mother, and all these results into low notification, low registration, low certification. There is no data on vital statistics from CRVS. There is huge backlog for children below 18. What health facilities can do? It can reduce the distance. It can substantially cut down the cost. It can simplify the notification process. It can make registration and certification one step, one visit process. It can improve cause of death data. Data capturing can be done at source. That in turn will improve quality and make data available on real time. It can also address socio-cultural issues like mothers can be counseled during ANC visits to be ready with names of babies. Unwed mothers can be informed about the registration process. Health facilities can also help creating awareness about the importance of registration. It can also create demand by checking birth registration status at vaccination or during health checkups. And for children aged 1 to 4 years, health facilities act as natural contact point for clearing backlogs. What health facilities cannot do, health facilities can serve only as the first contact point for registration and certification. It cannot undertake post-registration work such as search, demand for additional copy of certificate, correction, changes, etc., which a normal registrar is supposed to do. That's why in Tanzania, health facilities have been mapped to the nearest ward office for these activities. This chart shows the importance of health facilities in the new birth registration process. So a baby is registered within 6 weeks of birth, either through health facilities or through the nearest ward office. Way forward, health facilities remain critical in setting up a well-functioning CRVS system because of proximity to the community. They are between 5 to 6 kilometers. There is better coverage of health facilities, almost universal antenatal and vaccination coverage. Once you clear the backlog, the burden of birth and death registration is not so high. In return, health system also gets data on real time, and this can also provide effective linkage with the ward offices for post-registration work. Thank you.
Thank you very much, Bhaskar, for that presentation about the role of health facilities and how it can really support birth registration and hopefully in future also death registration. So our next presentation will be by Kathryn, and it's going to be about COMSA, particularly in Sierra Leone and Mozambique.
All right, good afternoon, and thank you for having us here. I'm going to be providing a very quick, hopefully not too rushed, high-level overview of a relatively new initiative that's being supported by the Gates Foundation to strengthen CRVS currently in Mozambique and Sierra Leone. It's called COMSA, Countrywide Mortality Surveillance for Action. The general idea is we are providing a catalytic investment up front for a few years to get a nationwide sample registration system set up, aligned with the country's CRVS strengthening plans and vision, and aligned with their existing capacity to make sure that we're doing something that's feasible and that meets their needs and their goals. We're actually, though, referring to it as an enhanced sample registration system, which I'll talk about in just a second. But once these systems are up and running, they should be producing routine, continuous data on births, deaths, and cause of death, and then generating those data and then feeding them to different stakeholders for use promptly and continuously, as well as to the public, not just to the government who need them. Now, the enhanced piece of this is the fact that we can tie the sample registration system at the national level into the Child Health and Mortality Prevention Surveillance, or CHAMPS network sites that the Foundation is currently supporting in 7 different countries with plans for expansion. And I don't have time to go through that in detail. I provided the website for more reference, or I'd be glad to talk through that afterwards in more detail. But the basic concept here, the innovation, is that we are able to do post-mortem minimally invasive tissue sampling, or MITS, among children under 5. And when those data are analyzed appropriately and interpreted appropriately, they give us much more precise information about causes of death than has previously been available. So in this sample registration system, we are able to do some focused MITs on some under 5 deaths, and then use that information to essentially validate or calibrate cause of death information nationally coming from the sample registration system's verbal autopsies. We are providing 3 to 4 years of this initial support currently in Mozambique and Sierra Leone. This provides the ability to engage external technical assistance. We are working from day one at the design phase on through implementation with National Statistics Institutes as the key local implementers, tying them in, though, in close collaboration with ministries of health, national public health institutes, and national civil registration authorities, and any other ministries that are engaged, such as the Ministry of Justice, for example. We've asked the grantees to design these systems in a way with very low running cost so that they can continue to be supported longer term. Essentially, a sample registration system, as most of you are likely aware, comes down to selecting a sample of representative enumeration areas all around the country. In Mozambique and Sierra Leone, the plans are to cover about 3 to 8% of each population with these areas. All of the then births, deaths, and pregnancies in these areas would be identified, recorded, and reported. And then all deaths that are identified would have verbal autopsy done. But since, again, we know the limitations of verbal autopsy in terms of identifying cause of death, we will also be doing MITs in conjunction with our CHAMP sites on a subset of about 200 under 5 deaths. Assembling all of the data that are coming in from the COMSA verbal autopsies, from the MITs procedures done through COMSA, as well as the many more being done through the CHAMP site, and any other sources of relevant data that may exist from surveys or from facilities, for example, or other surveillance systems. Pulling that all together and making some sense out of it, really, for the first time, so that we're able to calculate statistics, we're transparent about how that's being done, and we're sharing it rapidly with a variety of different stakeholders for use. And then finally, our basic concept, too, is that COMSA data needs to integrate with existing data systems, and that the data need to be made available as quickly as possible for different stakeholders. We also see COMSA is providing a platform for potentially raising local awareness in enumeration areas, for example, as a starting point regarding the importance of registering births and deaths, as well as potentially facilitating that registration process working with the CRVS authorities in a country. If there's an eCRVS system in place, as there is in Mozambique, for example, we're working with them to figure out how to align with them and support them and make sure that the data that we're collecting can be fed to them in a way that suits their system. We're also going to be able to use COMSA as a way to support training of nurses and doctors in coding of verbal autopsies, in coding of death and medical certification of cause of death using the standard WHO death certificates, and making sure, too, that that information gets integrated with DHIS2 in countries. We feel that once these enumeration areas are set up and reliably producing high quality and timely data, and that the system is functioning, that this essentially provides a platform that can be expanded upon. You can envision the potential to add other pieces into these enumeration areas, add other functions, or expand numbers of enumeration areas, or even shift location depending on how things may change in a country. We're also, as I mentioned earlier, working closely with various health authorities in each country, again from the design phase onward, to make sure that we are going to be able to produce data that they need and want and will use and see value in. So our first COMSA country is Mozambique. It's a 3-year grant. We're about 1 year into that grant. Our grantee is Johns Hopkins University. And in Mozambique, they have set up a sample of 700 enumeration areas all around the country, each with about 300 households. In each of these areas, there's a community surveillance agent who is engaged to basically be the eyes and ears of what's happening in that community, identify and report pregnancies, pregnancy outcomes, including stillbirths and deaths. Then it's a provincial team at each province that is overseeing the community agents and is responsible for arranging to do verbal autopsies on all deaths that are identified. These data then will be made visible to various different audiences with different levels of access, including the public, and also feedback is given to the provincial supervision teams to ensure that they're able to manage the work in their province. So in terms of timeline, we are just on the cusp right now of starting the initial household listing in the first 5 COMSA provinces, which are essentially all of the provinces in the north minus 1 that's in green. So we're just about to start that right now, and so we expect the events to be starting to be recorded over the coming month in that first half of the country, verbal autopsy data to start coming in subsequently. And then in the rest of the country, data collection should begin, listing and data collection should begin by middle of 2018, as well as doing this minimally invasive tissue sampling in Zambezia province. I am just going to really gloss quickly over this. This is just meant to show that there's a lot of work underway in Mozambique to figure out how to engage with the CRVS system that's in place and that's being developed. One example is that we're looking at the possibility of piloting in one province, having the COMSA community agents using the CRVS birth and death forms to be additional notifiers, essentially, directly into the CRVS system. I think ultimately we're excited, and they're excited too, about the fact that we'll have different data sources that can be used to compare against each other and get a better assessment of completeness of registration from the CRVS system, as well as accuracy. Our second COMSA country is Sierra Leone. This is a 4-year grant. The Center for Global Health Research with the University of Toronto is our grantee. Because of lower capacity at the start than we found in Mozambique, we've made this a 4-year grant rather than a 3-year grant. So in 2018 is currently a planning year, putting everything together, developing and finalizing tools, piloting, testing everything so that in 2019 they'll be able to hit the ground running and start listing households and collecting data. So again, this is very early stages, but the general plan is that it will likely be covering about 100,000 households. That's about 7 times more households than have been covered in previous surveys like DHS and MIX, and will allow us to get better data at the subnational and district level. A big part of COMSA Sierra Leone, too, will be the fact that we can continue to support the National Civil Registration Authority in their plans. It's a very nascent institution in Sierra Leone, very limited staff, very limited funds, and unclear mandate at the moment. So it's actually very timely that we're coming in right now, just as they're starting to formulate their plans. They're focusing right now more on the identity piece. So this complements it really well, as they don't have the resources at the moment to deal with the vital statistics and cause of death piece. We also expect that by the end of the 4-year grant in one district, and again, we're taking a slightly slower approach here given capacity constraints that are very different in Sierra Leone, but we'll focus on one peri-urban district, Bo District, where we expect that all of the health facilities, I believe there are about 130 there, should be using the standard WHO death certificate to do all of the facility death reporting by the end of COMSA. And again, the lessons learned there will be eventually scaled more widely across the country. So we're excited to see what is generated through these 2 different efforts. There's some similarities, but again, they're very country tailored and driven. And so we've got different approaches in 2 very different country contexts, and we hope to be able to evaluate those and have a better understanding of what works, what better, what works less in other settings. We also are currently in discussions, thanks to strong interest by the Minister of Health of Mali, who has basically said, why don't we have COMSA here? Let's make this happen. So we're trying to figure out how to replicate it there in the coming year, hopefully. And then ultimately, we would, though, like to see this spread more widely. By our estimates, there are at least 50 countries that could use strengthening of their basic capacity to collect high-quality, continuous data on births and deaths and cause of death. So we at the Foundation are working on a very robust and ambitious resource mobilization plan, trying to engage the interest and of other donors who work in this space and who have similar goals. So again, we're trying very hard on our end to generate more demand at the country level, as well as to bring other potential donors on board. Okay, thanks.
Thanks very much for also highlighting how other surveillance systems can really support CRVS. And then we have a final presentation by Sana, who will give us a totally different perspective of CRVS, looking at it through a social determinant of health lens.
Good afternoon. Actually, the MDG era, the international community was struggling to get data and to work on achieving the MDG, which came up with a number of initiatives which was very innovative. One of the innovative approaches that WHO used was to address the social determinants of health. A commission was developed in 2005, and the Commission had a strategy to address the social determinants of health, realizing that the health outcomes and the well-being is beyond the health system. And working in silo within one sector would not bring in the overall improvement in health outcomes and well-being. This presentation, I'll try to link how the social determinants of health and civil registration as a social determinants of health can be addressed at country level as and a new approach which is the intersectoral action on health. My presentation will include the definitions of the social determinants of health and the framework concept and the strategies that was addressed by the Commission of the Social Determinants of Health, and why and how we can address the civil registration processes and legal identity as a social determinants of health, and how we can address it using the intersectoral approach. This shows the variation. As you know, there is huge inequity between countries. If we take one example of the life expectancy, we see a wide range. In countries, it can be 48 years, the life expectancies. In other countries, it can be 82. There is wide variation between countries, and there is also wide variation within the country. Even in the developed world, there are huge variation within the country in the life expectancy. So this is one example. There are many examples which shows how the nutrition and the health outcomes are related to determinants that are beyond the health system, related to the social context. The social determinants of health definition refers to both the specific features and pathways by which societal conditions affect health and that potentially can be altered by informed actions. And the Commission came up with two levels of the determinants of health. And one is the structural level, and the other is the intermediate level. I will not go into the details because I will give time to how we can address in the future. As you know, there are many inequities which is based on the geographic disparities, gender inequalities, ethnic inequalities, socio-economic, and many other determinants that goes according to the country context and the community context, and it's variable. This is the social determinants of health diagram, which shows that it goes at different level. It starts at the individual level, then it's surrounded by the social and community networks, and it goes into the broader context of employment, living conditions, education, social environment, and education level, and other factors. And it's also within the context of the macroeconomics, the policies, structures within a government. This is the framework that was developed to address the social determinants of health, taking different variables and levels into account, looking at the policies and structures and the macroeconomics in a government, and at the intermediate level determinants, which is the education and occupation, and the determinants within the health sector. Why to address the civil registration as a priority SDH? We have been hearing the last 2 days the benefits and the effect of the civil registration on the health outcomes and on access to education, resources, economic benefits, and social protection. So the argument is there. Civil registration outcomes is a social determinant of health, and it is important to tackle it beyond one sector and using the intersectoral approach. It's a multidimensional issue. The legal framework is very important at country level. The governance, the policy, the macroeconomic and social determinants, the cultural and social norms, the social position, education, healthcare system, and many other factors. Civil registration, certification, and identity is a basic human right and allows individuals to have access to services. Civil registration quality data builds up robust vital statistics, which is very crucial for the health planning and development agenda at country level. Civil registration and vital statistics are shared responsibilities by a number of sectors, which goes beyond the boundaries of any government or department level. Innovative approaches as the intersectoral action to address the CRVS brings a unique opportunity to tackle the challenges already we see. How to address the civil registration and vital statistics systems? Of course, country level is not enough. We need to look at the global level, address the civil registration and vital statistics at the higher global agenda, one of the SDGs and its importance to the SDG, which will impact on the financing and allocation of funds to the CRVS. Regional level, the regional programs like the API CRVS, these are opportunities to support the CRVS systems at country level. So there is also consensus of the role of the regional programs in addressing this issue. At the country level, using the intersectoral committee and approach at the country level, this has been used since 10 years, and there are a lot of publications that showed how bringing many sectors together and having one strategy and one plan, one framework to address one topic has been very successful. And there's a lot of publications at the WHO website where the intersectoral action on health was used to address issues that the challenge was beyond the health sector. This was the final report of the Commission of Social Determinants of Health, and they addressed how inequities can be avoidable and fairness and social justice can address the issue, and there are needs to have more evidence and collect data and to work on monitoring and evaluation of the progress on these issues. At the global level, there are many factors surrounding the civil registration issues like fair financing for CRVS. We've been talking about the importance of CRVS, but when it comes to the global conferences and initiatives, little amount of money is allocated for CRVS. Till now, it's not a priority area at the global agenda. The market responsibility and involving the private sector is very important. Political will and the empowerment of policies and strategies at the government level, the gender equity, and we've been addressing this all yesterday, the good governance and good governance programs and structures for achieving the civil registration, and equity in all policies. Equity in all policies, now it's addressed that education sector, social protection sector should be all working together and addressing these key health and development priorities. This was an approach that was addressed by the intersectoral action booklet, and it goes, okay. And it describes the steps for how to go into the implementation of improvement of CRVS system using the steps of intersectoral action on health. This is like a suggestion. Now we're at the assessment stage, and there are initiatives for situation analysis, mapping of country-level CRVS systems, and this is a good opportunity to link it to the key problems at the country level and to start addressing these issues within sectors. Who are the related sectors, how to bring these sectors together, how to develop a strategy to address these sectors, and what is the framework, and how to monitor and evaluate the improvement and the progress done. Thank you for listening.
Okay. Right. We've got a few minutes, till about 25 minutes till we can have a question and answer and discussion. Remembering that this is being recorded, questions will need to come from the mics, so you just need to step up to the mics if you have a question or a comment or want to share your experiences of integrating health and CRVS. First question? Go ahead. Please identify yourself for the audience.
Morel Gomes, University of Toronto. My question is directed at Maletela around the GFF. My question specifically is how jurisdictional resource allocation issues are being mitigated. So specifically, from our country experience, we found that because Ministry of Health is leading the GFF investment case, a lot of the times other institutions that would be part of the broader CRVS agenda don't necessarily have access to creating that GFF CRVS ask.
Okay. All right, we don't have it. Go ahead, Maletela. Go ahead.
Okay, thanks. Thanks, Muriel, for that question. And I think it's a question that has been asked several times. As I indicated earlier, I think from the GFF's perspective, the fact that CRVS is being promoted to monitor maternal and reproductive maternal and child health indicators is where it was within the Ministry of Health. But in the past 1.5 years or so of the implementation, we realized that we can actually go beyond health to support CRVS systems. So that's what we are currently doing now to relook into other areas in which we can support. I think the key thing is making sure that there is that, because the GFF Trust Fund is operationally linked to IDA, to make sure that a country would be prepared to allocate financing from IDA to be matched with the GFF Trust Fund, because at the end we want to have a large-scale pool of funding to strengthen the CRVS system, which is why it doesn't go as a standalone trust fund, but linked to additional resources that we are taking as resources from the government. So we are going beyond just dealing with the Ministries of Health, but also expanding to go to other areas through which we can leverage on additional financing from IDA to strengthen CRVS systems. Thanks.
Yeah, I think it's important for all the partners to know that, looking at that new list of countries, to make sure those countries know that the CRVS partners need to also know that they need to step in and make themselves known to their health colleagues. Another question? Comment? Oh, go ahead, please.
Susan Stout from Development Gateway. We recently did a bunch of research at the local level on how much time people are spending on collecting various information reports, the traditional facility-based reporting. It's huge, 25 to 30% time, and it's not guiding them to reaching people outside of the facility. I'm wondering, in the GFF or in these country projects, are you beginning to work on using some of these data that come out of CRVS experiments for monitoring programs, and are we therefore able to reduce some of the excessive amounts of monitoring data that are being collected for various programs?
Like from the beginning.
Have we started to work on using the findings from the vital statistics that are coming out in monitoring programs, or is that still a bridge too far?
Thanks. I think that also relates, thank you very much for that question. I think that also relates to the very last point I made about not being able to use CRVS to do the monitoring, because in many countries that we support, registration is still paper-based, so you don't have a database from which we can do monitoring. But we are now encouraging countries to actually use the data that is currently available in whatever form for us to be able to assess and monitor, even just within the CRVS system, how well the system is performing based on the system itself, not based on the mix or DHS data that we'll get after 5 years. But the main problem is that the data is, the connection is still paper-based and we don't have a database. But we are encouraging countries to go beyond and try and use the data as it is. Thank you. I hope that addresses the question.
I think what's important to me is that the GFF is supporting this and not sort of saying, oh, well, and Maletela mentioned this, putting up another survey or another parallel system. It's like if really all donors and programs went in and built the CRVS system wherever they were working to get the data that they need, as opposed to saying it doesn't work, it'll never work if people don't put funding into it. So I think that's a really important message, and it's been very exciting to see the GFF say we're going to use CRVS data, so we've got to make it better. My colleague Annika, who's not in the room but helped organize this, and she said, when she was at WHO, she said, you just got to start using the data. Everyone's going to tell you it's terrible, and then you tell them it's your responsibility to make it better. But until you start putting it out there, no one's going to make it better. Teresa.
I just have some questions about COMSA. In my previous life, when I was working in HIV and AIDS, and we started to get funding for PEPFAR, and others know this here, we had ideas of helping to strengthen CRVS, but that was rejected because it wasn't HIV specific. So instead, we put a lot of our effort in sample vital registration systems with verbal autopsies, with COMSA sounding very similar to me. And I really don't know how well that really didn't build the CRVS systems. I don't know what's happening now, but I think that they kind of fell apart. And I'm just wondering what's going to be different about this as opposed to putting our efforts in building the CRVS as opposed to doing these sample vital registration systems.
Okay, Kathryn?
Like the savvy type of efforts that you're referring to that we've seen in various countries have been much more limited and focused in smaller geographic areas. I mean, we're kind of just coming out there and putting all of our eggs in one basket right now and saying there's huge gaps in data availability and quality. We can do another pilot in one province or two provinces or something, or we can just say, look, we really support this as the foundation. We see the value in collecting this kind of data, making it available, and getting it used. So let's do it nationwide. Let's do it country-led and tailored to a specific country context. So we're not coming in with a one-size-fits-all approach and saying, here's what COMSA looks like. You need to do it this way, and we'll get somebody to help you figure it out. Instead, what we've done, and I think this is a somewhat unique approach, is that, again, and I alluded to this during the conversation briefly, but we engaged with all of the national stakeholders as well as international stakeholders in the room from day one, from talking through what are the gaps they face, what are their needs, what are their plans for strengthening CRVS, what could we do that would fit into and support those plans. So that includes, there are a lot of complicated conversations, frankly, when you've got a lot of different ministries involved. You may have a parastatal, like in the case of Statistics Sierra Leone, for example. They're not officially a ministry, but they are tasked with providing all of the official vital statistics to the government, and that they are set up to do large-scale data collection. The Ministry of Health is not, but they're the ones who know the data that need to be collected, et cetera. So I think by getting all of these partners in the room repeatedly, I mean, this is like a year-long process of discussions and conversations around this, and getting them kind of used to working together in a way they hadn't worked before. I think that's going to be one really important piece of this, is generating that interest and that buy-in from all of them. It's also been really complicated figuring out, frankly, how to, what the management structures look like and the lines of reporting amidst all of these different entities. But with a lot of work from our grantees, it's come together surprisingly, but that's been a huge challenge. Another piece that we did differently was that when we were finally ready to go ahead and make these grants, we enlisted several different organizations who we knew were international experts in this type of work, had them submit proposals. We did an initial round of review, and we selected the top 2 proposals for each country. And then we flew the top 2 applicants to the country, and we had them present their proposals to all of the local stakeholders in the room, and had those local stakeholders do and lead the discussion. We weren't leading it. We were sitting back and saying, here, National Statistics Institute, you're leading this. This is going to be your thing, long term, and figure out who would make sense in your context. Ultimately, the local stakeholders were the ones who made a final recommendation to the Gates Foundation in each country to say, this, based on what we've heard and read, and all the conversations we've had, we feel this particular grantee and this particular approach makes most sense. So again, we've had that buy-in, and we've heard from them repeatedly how unusual that process was and how much they appreciated that engagement. So I feel like a lot of this, again, we're trying to take a slightly different approach, that we're not just coming in saying this is a one-off Gates Foundation funded project and figure it out after we're done. And we're working with developing costed sustainability plans in each country. We're working in on resource mobilization widely amongst different donors, and really trying to make this work. So I think time will tell as we go through it. It's too early to say yet, but we're really trying to go in it with hitting it from all the angles we can to make sure that we don't see a situation like a Savvy, that funding disappears and the system falls apart, and that's that.
Other questions from other panelists? I also have sort of a question for COMSA, since no one stood up. I think one of the points about Savvy is that it thought it would help build the CRVS, but it didn't. And so besides the sustainability issue. And I think it sounds like that in the places that you're doing the COMSA, that you hopefully will be actually helping to build the notification systems with the various partners. Clearly, it also looks to me like it's mostly, one of the issues is the verbal autopsies, which you obviously can't do on every single death. And so how would you see going forward beyond the places where you're doing the sample registration, which is where you're trying to set up verbal autopsy, better cause of death data, but building the CRVS system outside of, like you said, it's national, but outside of, at least for reporting of deaths, outside of the COMSA districts?
Could you kind of repeat the final piece of
Okay, that? Just how assuming that the sample vital registration is able to continue, that is a lot of focus on getting good cause of death through verbal autopsies and other issues. But in other parts of the country, you're not going to always do verbal autopsies on all deaths. But how are you going to build the system as a whole outside of the COMSA districts, at least to get reported deaths, on which you could then use the good cause of death to extrapolate outside?
So, I mean, again, with the sample approach, obviously we're just going to focus on our sample registration areas and get that high-quality data in a way that's representative nationally and subnationally, and use that at that point. But in terms of then working with the national civil registration authorities in each country, that's where we're still sort of in progress, I think, with Sierra Leone in this planning year. That's a big question, is what is it that we can contribute to help them build their capacity? And is it just, is it more the broad training in coding and certification? That's a piece of it. Is there something we can do on the raising awareness area? Because we understand this is a very slow, very long process, especially that civil registration piece. I think, again, we're from the global health area at the foundation, so our focus is more on the vital statistics piece of it, but recognizing that in order to be successful, it has to also contribute more broadly to CRVS. So I think it's a bit of it's in flux at the moment, and I think that in Mozambique, where we're about to start the data collection, we are having lots of conversations with the CRVS authorities regarding how do the data coming out of COMSA feed into their system, and how can they strengthen their system using lessons learned that we gain in our sample areas. We have our grantee in the room. I don't know if I want to put him on the spot for Mozambique. I don't know if there's anything else, Agbesi, that you would like to add specifically to the COMSA Mozambique experience, or if I covered it generally enough.
Just to make a brief comment on the CRVS. I think when we approach the CRVS, there's some misunderstanding that happen. The CRVS is a legal system that the country has and protect. And maybe my colleague from Cameroon can speak to that better. So to bring a system that is outside to connect to CRVS, it has to be done very carefully. And so we are building COMSA, health, trying to connect to the CRVS. And by law, CRVS is regimented by law, in the country. It's not just a system that is put out there like that. By law, it has to be somebody from the CRVS that actually certifies that this event occurred and register the event. So we get the data, we make the data. So the discussion we are having now, which Kathy presented, we are willing to use the form that the CRVS has, the country has formally developed. But COMSA cannot formally register the event. COMSA will collect the data, make the data available to CRVS. Then CRVS will have the authority to double-check those data, those events, and then decide to register them. So there are these things that you have to be aware of. And the second part is the verbal autopsy part. So the verbal autopsy doesn't go directly onto the CRVS, right? The country has to make the decision between the certification of the deaths and the verbal autopsy, which one whether they'll decide to take verbal autopsy because the certification is not complete. That's one question. Now, there is this vital statistic portion, right? The vital statistic portion does not require completeness. It requires, so long that we have a sample data, we can generate some statistics, which COMSA will produce. But those don't fit into the CRVS system. They will generate statistics that the country will use for health planning and so on. So I'd like to make those clarifications. Thank you.
I think it's important where, we're having this session to talk about how we can work together to help each other. So I think that I think the whole issue of verbal autopsy, we've talked about that. I've talked about that, people that, it takes a while to get a verbal autopsy. We deal with the same things with injury deaths or homicide deaths. It takes a while to get a final cause of death, and that often doesn't get back into the actual death certificate. And is that something that we should be doing, or we should just say, no, that's crime statistics or verbal autopsy statistics or something like that, or can we work better together? Bhaskar, you wanted to make a comment?
My only worry is that
sample registration system should not be done at the cost of CRVS.
Mm-hmm.
This is what has happened in India. Like I was Deputy Registrar General in charge of CRVS as well as sample.
Can you turn his mic on? Sorry. Is it on now? If not, come on. Oh, I see why. It's on the floor.
What I'm saying, my only worry is that sample registration system should not come at the cost of CRVS. This has happened in India, like the Indian sample registration system initially came for 10 years. Now it has become a permanent system and CRVS still lags. That's my one concern. Second concern is, sample registration system will give you data on fertility rates, starting from crude birth rate to TFR, on mortality rates, starting from crude death rate to maternal mortality ratio, etc. But there has to be a linkage between the two, because sample registration system should not continue for infinite time. It's a good beginning. It can help you set up a system, but then finally you need to have a good CRVS system in place.
Mm-hmm. Mm-hmm. Maybe Bhaskar, could you speak about what you didn't get to say this because you only had 10 minutes. I've seen your full presentation. What you had to do to have the health workers be more engaged, and actually, because you did have to change some of the way the laws were working and who was authorized to do what, and what did you have to do to make that work, to make health more engaged?
I think the new system is governed by a tripartite MOU, which is among three ministries: the Ministry of Constitutional and Legal Affairs, Ministry of Health, and Ministry in charge of local government. So the idea is, even now the notification was done by health facilities, So as part of that MOU, these health facilities and ward offices, they were delegated this task. Mm-hmm. Initially it was difficult because they did not perceive as it as their own work. They thought that, okay, this is the responsibility of FIDA. I think this is an overburden to them. But slowly and gradually, with training, we did not incentivize them, like directly in terms of money. But because of other issues, slowly and gradually, they understood the importance. For them, because the birth is taking place at health facilities, they have all requisite information. And if you designate them as registration point, instead of doing notification, they'll do registration and certification.
Mm-hmm. Mm-hmm. Yeah, so it
because in 2018, we should not be talking about notification. We should talk about registration and certification.
Okay, yeah. So in the digital age and through other ways, yeah. So it is possible through memorandums and things like that to actually get health workers to do the work, which is...
And the learnings from this new system have gone into the legal review work. So decentralization, fee waiver, one-step, one-visit process are the key features which will come in the upcoming Act also.
Okay, great. Any other questions or comments? Are people ready for the... yeah, we've got like 1 minute before our colleagues will start coming back here for the final. Okay, I think I'll let Anshu do a final sort of closing. No, keep doing. Yeah. Okay. All right. I was just going to let him do it. But thank you so much. I think I've noticed that the CRVS community, there's people like me and Bessie and the demographers, epidemiologists, the data wonks. And then there are my other colleagues on the protection side, who are sitting over there. They're on the human rights side. And I think actually one of our, and so we need to come together. And I always say that health is the primary provider of data, certainly for births, deaths, and stillbirths, and also the primary user. And so we've really got to get our health colleagues to be involved and see it as part of their work, whatever the law is in the country and whatever you can do. And I think that a colleague, I think he was from the Africa Bank or Africa Commission in the previous session that I was in, our earlier session I was in, and someone asked him, is this a human-centered approach or a data-centered approach? And he said that he felt like that CRVS was the one thing that a demographer does that's actually human-centered because it gives people their rights. So thank you very much. And so health, we care about that too. Thanks.